Video we're going to talk about glomerular disorders. Okay, so glomerular disorders are broadly classified into two types: nephrotic and nephritic syndromes. So in nephrotic syndrome, what will happen is that we're going to have proteinuria. Okay, so what is proteinuria? Proteinuria is excessive loss of proteins, all kinds of proteins, different kinds of proteins in the urine. Okay, so in nephrotic syndrome we're gonna have more proteinuria. Okay, so this means if you put it quantitatively, it is more than 3.5 milligram per liter. Okay, so if this much 3.5 gram per day, if you're losing more than 3.5 gram per day of proteins in the urine, that will be nephrotic syndrome. How I remember it is by more has O in it as well as nephrotic has O in it. And what is nephritic syndrome? It is less proteinuria. Okay, less proteinuria. So it is less proteinuria. And how much? It's less than 3.5 gram per day. Okay, now of course this is a broad classification. They are classified furthermore, so I'm going to give you guys a list that we are going to go through in this particular video. So here is the list of all the nephrotic and nephritic syndromes that we're going to go over in this video. So we have minimal change disease, FSGS, membranous nephropathy, membranoproliferative glomerulonephritis, and diabetic nephropathy in nephrotic syndrome. And in nephritic syndrome we have PSGN, RPGN, IG nephropathy, and Albert syndrome. And we are actually going to draw a comparative table for this. So here is the comparative table that we are gonna follow for nephrotic syndrome first. So this is for nephrotic syndrome. Now, an important consideration is that why are we even making this comparative table and what is the point of doing this? So first we're gonna look at the etiology, and then we're gonna look at the gross structures. Then we're gonna, LM means the light microscopic findings, EM means electron microscopic findings, and IFM means immunofluorescence. Okay, so I'll write it. Let me zoom it. So this is light microscope, this is electron microscope, and this is immunofluorescence. Now, we don't usually do electron microscopy and immunofluorescence for other pathology related things, as we know, we've done different pathologies, if you know, but in this case we are doing this. So I'll give you a little idea why are we even doing this. So for gross is what it appears for the naked eye. Okay, so that's the gross, and you're not gonna find gross features for all the conditions that we're gonna do today. You're gonna only find them for some. Then we have the light microscope. Light microscope are normal H&E stain. So what is it? It is normal H&E staining. Okay, eosinophil. Okay, so that's the thing. So we normally always check pathologies in a light microscope. And for electron microscope, what we want to do is want to see the location. Okay, location of what? Location of the deposits. Now I will tell you in the video that in different nephrotic syndromes there are different deposits that are being formed in different nephropathies. Okay, and glomerulonephritis, different types, and there are deposits formed. To know where they are exactly located, okay, that will be its electron microscopy. And for immunofluorescence, we are saying its composition. Okay, so we will know the composition of the deposit. So these all things are of the deposit. Okay, so that's that. Now let's start with the nephrotic syndromes. We are gonna first look at minimal change disease. So for all the nephrotic syndromes, I'm gonna save some peace of mind and tell you that there is nothing that you need to know about how it looks on a gross to the naked eye. So there is no gross locations. Okay, so we are going to not do this column, right? But still, there are some things that we need to do. Instead of the gross column, I'm gonna write here the medications. Okay, so it is going to be the medications instead. Okay, so for minimal change disease, what we need to know is that it is for etiology. Let's do etiology first. Etiology, that it in which age group it's more common. It's more common in children. Okay, and mostly it is idiopathic. And but if someone has Hodgkin's lymphoma, you might find it in the patients of Hodgkin's lymphoma. Okay, now why is it so? So let's we're gonna come to drugs later on. First, let's discuss why this happens, okay, and what is it. So I'm gonna go down here and we're gonna do minimal change disease. Minimal change disease. So I told you that it works, it happens in children and in the patients of Hodgkin's lymphoma. Why is it so? Let's look at that. So basically, if there is any kind of atopy or allergy, the both are the same things, or there is vaccines, if someone has vaccines, or Hodgkin lymphoma, in Hodgkin lymphomas there is increase in cytokines, right? So all these leads to increased cytokines because of overactive immune system. Okay, so due to overactive immune system, what happens, what is going to happen, that it is going to go, these cytokines are going to go into the kidney, and in the kidney we know that the glomerular area, that is made up of podocytes. Okay, the basement membrane, the GBM is made up of podocytes. So these podocytes, they have something that is called as the food processes. Okay, these are the food processes of podocytes. Okay, so not only the podocytes, so these globular structures are the podocytes, and above the podocytes these are the food processes that basically makes the glomerular basement membrane. Okay, so these cytokines are actually going to come and damage these food processes. When you damage these food processes, what will happen is that you're gonna damage the negative charge will disappear. It will disappear, and because of the disappearance of the negative charge, the glomerular basement membrane is going to become more leaky to proteins. That is why this disease is called as minimal change disease, because minimal change is occurring. What is the minimal change? The only food processes are being damaged, the podocytes are not being damaged. Okay, only the food processes of the podocytes are being damaged, not even the whole cell. That's why it's minimal change, and that is why it is losing what? It is losing the negative charge. When the basement membrane is losing the negative charge, it will not repel the negative charge proteins, and the proteins are going to be more leaky then. So that is minimal change disease. So let's see what you will see on light microscope. Now on H&E stain, what are you going to find? Now I told you that it is minimal change disease. So because it's minimal, so a very minute amount of damage is being done. So H&E is going to be normal. Okay, H&E will be normal. But what are you going to see on electron microscope? The location of the disease process, I told you. The location of the disease process will be found. In minimal change disease, what is happening? Effacement of food processes is happening. Effacement of food processes of podocytes. Okay, so that's that. On immunofluorescence, what are you going to see? In immunofluorescence, you are going to see nothing. It will be negative. Why it will be negative? It will be negative because there is no immune complexes formed, right? So because there are no immune complexes, so it is going to be negative. See, this makes it simple. What are the drugs you can give to this patient? excellent response to steroids. Excellent response to steroids. Okay, so that's, we have done minimal change disease. Only one thing that I want you to know is that in this case we're gonna have selective proteinuria. Okay, so keep that in mind, it will be selective proteinuria. So in minimal change disease we have selective proteinuria. And what kind of proteinuria? Only albumin will be released, albuminuria will happen. Okay, it is selective to albumin. Okay, but no immunoglobulin, so there will be no immuno compromise. Okay, next is the focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis. In this we have the etiologies are, it is also idiopathic. Okay, it is also idiopathic, but you find it in Hispanics plus African Americans. Okay, so why do we need to know this? We need to know this because we can read clinical vignettes with this. If we know that there is a child coming in your clinical OPD or in the clinical vignette, and you see that there is a child who has this excessive proteinuria, okay, and has edema, periorbital edema and all that, and or maybe he has a history of if an adult is coming and he has a history of Hodgkin lymphoma, you know, these are clues for that the examiner is pointing towards minimal change disease. So if it's idiopathic or a person who is coming, he's Hispanic origin or he's African American, you know, it is pointing towards focal segmental glomerulosclerosis, right? So that's that. But important associations with FGS is, you need to know that it might be associated with patients of HIV or patients of heroin use. Okay, heroin use, or the patients of sickle cell disease. Okay, sickle cell disease. Okay, so let's see how this develops. Now in focal segmental glomerulosclerosis, you need to know that what does this term even mean. Okay, so what is focal? So focal is only some part, not all, some. So there are two things that we need to dissect. First we need to dissect is focal, and second we need to dissect is segmental, right? So focal means that some part, some glomeruli are being involved in this disease, okay, who are undergoing glomerulosclerosis. And segmental mean that a little part of this some glomeruli, okay, of this already some glomeruli, on little part of that glomeruli are being affected. Okay, I'll tell you what that means. So for example, look at, this is a kidney. Okay, this is a kidney that just made a heart. That's funny. So let's see, this is a kidney. Okay, and in this kidney we have pyramids, right? We have pyramids. Let's see, in any part of this kidney, any part, okay, this glomerulus is being, this part of the kidney is affected with FGSS. In this part, what is mean that, let me zoom it here. If you zoom this here, what you see is that there is glomerulus. Okay, so there is one glomerulus, there is two glomerulus, 3, 4, 5, 6, 7. Okay, so what does focal mean here? Focal means that only this and this is focal. This is the meaning of focal. This part is being affected, by, okay. And what does segmental mean? The already affected focal glomeruli, some part of that glomeruli are going to be affected. Okay, so little part of already affected focal glomeruli, that is focal segmental glomerulosclerosis. I hope that made sense. I try to simplify it for you guys. Okay, so what's next? The next is the LM finding. So what are the light microscoping finding? This I told you. What is the light microscoping finding? Focal, right? That is, I'm sorry, focal means some glomeruli, they are affected, okay. And segmental means only a part are undergoing glomerulosclerosis. So you will see sclerosis of glomeruli, but what kind of glomerulosclerosis? Focal and segmental, okay. Let's see what you're gonna find on electron microscope. So what do you find on electron microscope? Simple. You find what? You find effacement of food processes. It is the same, okay. The disease is the same. You find what? You find effacement of the food processes. Effacement of food processes. That is in the EM stain. And in immunofluorescence, what do you find? In immunofluorescence, you're going to find a negative, right? It will be negative. So you see, with this comparative table, it becomes easier to differentiate, right? It becomes easier to differentiate. If you just go and read Robbins, it's a lot. And Robbins, I tried it. I failed miserably. Pathoma is good. I like Pathoma. It's still better off than others. Okay, let's now do membranous nephropathy. Now for membranous nephropathy, what is etiology? It is common in Caucasians, okay. But you need to know with this that it is associated with hepatitis B, hep C, and solid tumors, okay. Solid tumors plus usage of NSAIDs and usage of penicillin is also involved. So if you have a case, if a person is on NSAIDs, or he or she is abusing NSAIDs, or let's see if a person is of hep C or hep B patient, right, and they come with excessive proteinuria, that's a clinical cue. That's membranous nephropathy. The person is trying to tell you it's membranous nephropathy. So let's see, we have a lot of things to understand here, and so it's a big topic, but we're gonna take it. Now, what is happening in membranous nephropathy? Now, for membranous nephropathy, diabetic nephropathy, and membranoproliferative glomerulonephritis, there is a basement membrane problem, okay. What is happening? The basement membrane is getting thickened, okay. So that is why it is called as membranous nephropathy, okay. That is why it is called as membranous, because the membrane is being thickened. So GBM will become thick. Another thing, that for only membranous nephropathy, now I'll talk about membranoproliferative as well. What is happening? There will be now immune complex deposits will be made, okay. So let's see what kind of immune deposits, okay. So I told you the etiology. Let's go up, right. So here we see for membranous nephropathy, for light microscope, what are you going to find on H&E stain? On an H&E stain, what you will find? Thick glomerular membrane. It will be thick GBM, right? And then what is for electron microscope? Electron microscopic findings, you're gonna find what? You're gonna find spike and dome appearance. So what is spike and dome appearance? Spike and dome appearance, I'll tell you that there is, for example, let me zoom here, okay, and I'll show you here if I can. Spike and dome appearance means that, see that this is the glomerular basement membrane, okay. This is the glomerular basement membrane, and this basement membrane we are gonna have and then there we have the endothelium, okay. This is the endothelium. So glomerular basement membrane, the endothelium, okay. There will be a subepithelial deposit. So this is a subepithelial deposit. This one is, and this one is. What happens that epithelial cells on this deposit, what is this deposit? You need to know. This deposit is immune complexes. So what are immune complexes? Immune complexes are antibody antigen complexes, okay. Antibody antigen complexes are immune complexes. Over these immune complexes, epithelial cells will deposit. That is why it is called as a spike and dome. So you see the dome is being produced, dome and a spike. spike, right? So that is spike endome appearance. And what is this? What is spike endome appearance? That is nothing but subepithelial deposit. What do you call it? You call it subepithelial deposits. Okay, write that in bracket. That's that. Now let's see what are you gonna find on immunofluorescence. Now guys, we have an immune complex, so it is going to show up on immunofluorescence, right? So whenever you're gonna have subepithelial deposits, what kind of IFM are you gonna have? You're gonna have a granular immunofluorescence. So it will be granular because of positive for immune complexes. Okay, I hope this makes sense. Let's now do membranoproliferative. Okay, let's now do membranoproliferative glomerulonephritis. What happens here? In membrane proliferative, now there is no etiology that was mentioned, so mostly this also happens because of some kind of immune surge. Okay, some kind of immune surge, so you can leave it as is. And for HNE, what are you going to find on HNE? Again, it is a membranoproliferative glomerulonephritis. It will have a thick basement membrane. It will be a thick glomerular basement membrane, right? And what will be the electron microscopy, right? Now, thick basement membrane with tram track appearance. Tram track appearance. First, let me explain this. So, what is tram track appearance? Tram track appearance is tram track appearance. Before doing HNE, we first have to do the two types of membranoproliferative, and then you will have a good idea what is tram track appearance. So let's first do that. So in membranoproliferative glomerulonephritis, you need to know that there are two types. Okay, there are two types. Simply type 1 and type 2. Okay, now these types are based on electron microscopy. Okay, HNE stain will be tram track appearance. I'll tell you how that is. It is a very simple concept. But type 1 and type 2, how do you differentiate? Division is based on location. This division is based on location. And how do you see it? By electron microscopy, right? So type 1 is called as subendothelial. It is what? It is subendothelial, and subendothelial is associated with HBV and HCV, hepatitis B and C, hepatitis B and C. And type 2 is called as dense deposit. Okay, dense deposit disease. And what happens here? Okay, so it's simple. The subendothelial one is simple one. You will have nephrotic syndrome here. But in dense deposit disease, what happens? That there is a factor called as C3 nephritic factor. C3 nephritic factor. It is the same kind of like a brother to that of the complement system, right? You know the complement system. So that is the same, but it is present in the it was found in the kidney, so we call it C3 nephritic factor. It is the same deal. What it does, it goes and it activates C3 convertase. It activates or stabilizes, it stabilizes C3 convertase. It doesn't activate it, it will stabilize. And now because of this, when this is stabilized, C3 will decrease, and because of that, due to low levels of circulating C3, what will happen? It will not form C3 and C3b. Okay, so what does C3 does? Usually that C3 will convert C3 into C3a plus C3b, and the complement is then going to work. It's an opsonin, right? So it won't work because C3 nephritic factor, which is an autoantibody, it has stabilized C3 convertase. It is no longer doing. So the C3 levels are going down. Plus there will be more inflammation. There will be more overactivation of complement system, right? So it's not happening. That is why this C3 plus these are now a immune deposit. That is why they are called as dense deposits. Okay, so this is going to get deposited. Okay, so when this is getting deposited, what are you now going to see? You are going to see on H&E, okay, because of a problem electron microscopically, what you're going to see on light microscope is a TAM track appearance. What is happening? That we have this membrane, okay, this is a basement membrane, and in the basement membrane we have deposits. We have deposits. These are deposits, but what is happening? What is below it? These are mesangial cells. These mesangial cells are proliferating, and these proliferating mesangial cells will proliferate in between the deposits, and you see it becomes a TAM track. What is a TAM track? A railroad, right? Something like that. So this is a TAM track appearance. Okay, the mesangial cells will proliferate in between the deposits. Okay, that's that. So now let's fill up the table. So on H&E we have the TAM track appearance. On EM we have type 1 and type 2 types. I've already told you what types are those, so you can fill it up yourself. And what is the immunofluorescence? That is granular because it has immune deposits. Okay, it has a poor response to steroids. And membranous nephropathy also has poor response to steroids, and this also have poor response. Okay, I'm sorry I did not tell you before, I forgot. Poor response to steroids. Okay, let's do last and then we can move on towards the nephritic syndrome. The video is already half hour long. Let's do diabetic nephropathy. Okay, now this needs a little bit of exploration, so let's do that. Okay, now diabetic nephropathy is a big topic. Okay, it's a big topic, but we are only going to talk about, so I'll give you a little overview about diabetic nephropathy. What is happening? The culprit. What is the culprit? NEGs, non-enzymatic glycosylated proteins, right? Or glycosylation, non-enzymatic glycosylation, just know that is the main culprit. Okay, what is going to happen because of this culprit? Three things. Usually in diabetic kidney, three things happen. One is the diabetic microangiopathy. What it is going to affect the renal artery. Okay, it is going to affect the renal artery. We're not going to talk about that today, but we are only going to talk about one thing, and I'll tell you what I'm going to talk about. So microangiopathy. In microangiopathy, what is happening? The capillaries are being affected, right? The capillaries are being affected. And then the third thing, what is the third thing? The nephropathy itself, okay, which is called as nephropathy itself. In nephropathy, then we have three things that happen. So we have glomerulosclerosis, then we have arteriosclerosis of the glomerular capillaries, and then we also have pyelonephritis. Okay, pyelonephritis, but we're only gonna today talk about glomerulosclerosis. Okay, we're not gonna talk about anything else. So let's see how glomerulosclerosis happens. Now glomerulosclerosis are of two types. Glomerulosclerosis are of two types. Both come under the category of nephrotic syndrome. Okay, now here there are two. One is the diffuse type, and the other is the nodular type. Diffuse type means that it is covering the whole certain part of the kidney, but nodules are small nodules of sclerosis are found. See, so in diffuse we have four things. There are four areas where problem is present. Okay, four areas of problems. What is the first area? What is going to happen? The first thing, the hyaline deposit is going to be in mesangium. Okay, hyaline deposit in Diabetes, I told you that there are NAGs, and NAGs are gonna form what? Hyaline deposits. I'm sorry, I forgot to tell you this important concept. So we're gonna have what? We're gonna have hyaline deposits, okay? Very pink. You see the HNE, it's really pink, okay? So in mesangium, the number 2, where else? So we have 4 things that you need to know about. Number 1, it will deposit where? In mesangium. Number 2, it will deposit on the top of the capillaries, which is called as a fibrin cap. Fibrin cap, where on top of the heads of capillaries, or however you want to remember this, okay? You see in a stain, google that stain of a diabetic kidney, especially diffuse one, and you see a fibrin cap. That's the cap of the capillary, okay? Third one is what? It is a capsular drop. It is called as a capsular drop. Capsular drop is a thickening of a capsule because of hyaline deposits, okay? So it's a thickening of what? Thickening of capsule. Then in fourth, what we have left, that is the glomerular basement membrane thickening, okay, because of hyaline deposits, okay? So this is a diffuse type. What happens in the nodular type? In nodular, there is going to be nodules in the mesangium, okay? Nodules in the mesangium. It's only one thing that you need to know in the mesangium. And what are those called? These are called as Kimmel-Steele-Wilson nodules. Learn this name. Kimmel-Steele-Wilson nodules, okay? So these two men came together and discovered what? The nodules, okay? So this is the things that you need to know. You need to know these things, important. Most of the questions are with this. You need to know the nodular one, right? Now let's complete the table. So in the table, what are you going to write? What is the etiology? Hyperglycemia is the etiology. Hyperglycemia is the etiology. And there are no drugs. The drugs are diabetic drugs, of course. On HNE, what you're going to find? Diffuse glomerulosclerosis. And what else? Plus, what else you're going to find? You're going to find nodular glomerulosclerosis, okay? I've told you all the salient features. And there is no electron microscopy. It's not used because we have seen already on the HNE. Why do electron microscopy when we already have one, right? So because the deposits are not immune complexes, right? So you're not going to have any immunofluorescence, okay? So one thing I think I did not tell you guys is the clinical features of nephrotic and nephritic syndrome. So let's do that first. I told you there is proteinuria, but what else can happen? And then we can move on towards nephritic syndrome. So I'm sorry for this, but let's do nephrotic syndrome, some points, that the clinical features that you're going to see in nephrotic syndrome. First, of course, proteinuria, I've told you. Then we're also going to have hypoalbuminemia. Okay, what is this going to do? This is going to cause edema. Okay, then we're also going to have hypogammaglobulinemia, less gamma globulins. Okay, this is going to increase the risk of infections. What else? We're going to have a increase because we have a loss of, so we will have loss of antithrombin 3. You know, antithrombin 3, what it did? It stabilized the platelets and prevented it from making a clot. So if AT3 is not present, so usually what AT3 does is that it stops clotting. Okay, it stops clotting. If it's not present, it is going to cause more clot. So hypercoagulable state. Hypercoagulable state. Normally 83, it decreases coagulability, okay? And then if there is loss, it's going to be hypercoagulable state. Then lastly, due to an unknown reason, hyperlipidemia occurs because body is losing proteins. The liver thinks that the compensation to loss of proteins are what? Increased fatty acids. So such a nerd is the liver, right? he doesn't know what he's doing, so he just increases fatty acids. So that's the reason, unknown reason. We don't know why he does this, but I think he does it because he is a Gen Z chat. Okay, so now let's talk about the things that happens in nephritic syndrome. Nephritic syndrome is a very easy one. There are only 4 things that you need to know, and then we will be complete for today. In nephrotic syndrome, what happens? Let me change color. Okay. In nephritic syndrome, limited proteinuria. I told you. What else? Oliguria plus azotemia. Okay, azotemia is a renal failure type. Okay, then we also gonna have what? Salt retention. And because of this salt retention, what is gonna happen? Edema this will lead to edema. This will also lead to hypertension. Okay, what else? Because of nephritic syndrome, damage is there. So this damage, what happens? That RBCs, we're gonna have hematuria. Okay, microscopic hematuria will be there. We call it microscopic hematuria. And because of this microscopic hematuria, you know, it's important, ultra important. We have RBC casts in the urine. Okay, RBC cast in the urine. Okay, because of glomerular bleedings. All right. Let's now do the nephritic syndromes. Now the nephritic syndromes are only 4, and they are very easy. First is the post-strep glomerulonephritis. So what happens in a post-strep glomerulonephritis? Let me take out my notes. Okay, what happens in post-strep glomerulonephritis? There is an infection. We know that if you watch Sketchy Micro, right? So you know that there's a very nice sketch about Streptococcus pneumoniae. So that's that. So strep, what is the etiology here? The etiology is group A beta hemolytic strep infections. Okay, so if you usually, I hope that you all guys do micro from Sketchy, because micro from Levinson is always very difficult, right? So if you know this. So what happens now? You need to know this. In post-strep glomerulonephritis, what happens? It is in the name, post-strep glomerulonephritis. After a strep infection, the patient is having glomerulonephritis. So usually what happens that after 10 to 14 days of a pharyngitis, or impetigo, after 10 to 14 days, the patient will have a glomerulonephritis. That is what is post-strep glomerulonephritis. Now what happens in post-strep glomerulonephritis? Now it's important to understand this, so let's do this. So in PSGN, what will happen? That in response to a bacteria, that is, I told you what kind of bacteria it is group A beta hemolytic strep 1, and it's nephrotogenic strains. Okay, these strains have an M protein. Okay, M protein in it. This M protein is what? It is a virulence factor. You call them a virulence factor. Okay, what will happen that these bacteria, they will go and sit on the basement membranes, and the antibodies against this, they will come behind them and they're gonna get deposited. So antigen is what here? It is the bacteria, and the antibodies will come running behind the bacteria. Okay, so that is the main pathogenesis. That is it. That is the only thing that you need to know. Now let's fill up the table. So on gross features, you're gonna have a flea-bitten kidney. It looks like it. It's of course not bitten by fleas, but it looks like it is bitten by fleas. Okay. So what are H&E staining? The H&E shows hypercellular plus inflamed glomeruli. See, because there is an inflammation, there is a freaking bacteria there, guys. Of course there can be inflammation, and that is what the HNE stain is going to show you. What will be the electron microscopy? You're gonna find subepithelium humps. Subepithelial humps. Remember this, very important. Subepithelial humps. Okay. And what will be immunofluorescence? Immunofluorescence of PSGN have what? It has IgG antibodies, IgG antibodies against the bacteria. It can also have the C3 granular factor, okay, C3 granular deposit. So it is granular, okay. It will have IgG and C3, and it will have granular deposits. So that is the composition. The important one is IgG here, okay. That's it for post-rep. Now let's do a RPGN, that is rapidly progressive glomerular nephritis here. Okay, let's do this. This has 3 types. So RPGN has 3 types. Type 1 is Goodpasture syndrome. It's called what? Goodpasture syndrome. Okay, in Goodpasture syndrome there is auto antibodies against what? Against the glomerular basal membrane, okay, and it is linear. Okay. Then type 2 is same. It is exact copy of PSGN. It is just progressive PSGN, okay. And type 3 is posse-immune. You call it posse-immune. Why? Because it is cell mediated. It is cell mediated by CD8 cells, okay. It's not even that much important, just know the types and that's it. What are you gonna find on LM? You're gonna find crescent formation, okay, in Bowman space. Important. Where? In Bowman space. Why do you find this? What is it made of? It's made of fibrin plus macrophages. I told you, it is either it is autoimmune, either it is caused by the strep bacteria, or it's posse-immune, cell mediated what? CD8 types of cells, okay. CD8 cell mediated damage. What are you gonna find on HNE? Sorry, ENM. We did HNE, na? What are you gonna find on ENM? Type 1 is linear. It is epimembranous, so linear deposits. Type 2 is humpy dumpy, right? Subepithelial humps. Subepithelial humps, because it's the same as PSGN, right? So it is subepithelial humps. And type 3 has no deposit, because it is what? It is cell mediated, right? So the IFM, what will be the immunofluorescence? Immunofluorescence will be linear for type 1, Type 2 will be granular, same as what? PSGN. And type 3 will be negative, or it can be scanty as well. So that's that. What is the important thing that I need you to know from rapidly progressive is PSGN type 2, okay. Type 2, you need to know the type 2. Let's do Alport syndrome. Alport syndrome is, it is what? It is an inherited defect in type 4 collagen. Inherited defect in type 4 collagen is problematic, okay. In what chain of collagen? Alpha 5 chain. So how do you write this? You write this as COL4, collagen type 4, alpha 5, okay. You write this, and this is X-linked dominant, okay. What do you see on HNE? You see a lot of things. You see important thing, basement membrane splitting, GBM splitting is very, very important. You need to know this, okay. It is glomerular splitting. What else? Thinning, splitting plus thinning, okay. It's thinning. There could be mesangial cell proliferation, tubular atrophy as well, it could be seen, but important one is glomerular membrane splitting. And electron microscopy is basket weave appearance. Basket wave appearance. You just remember this. Why is this so? Because of alternate thickening. See, what do you know basket weave? How does a basket weave appearance is? Like this. So this is a basket weave appearance. So I told you like thinning and splitting. So there will be thickening. That is why alternate thinning. That is going to give a basket weave appearance. Okay. So last one, IgA, and then we will be done after this. IgA nephropathy. This is the most common nephropathy. What is happening in IgA nephropathy? It could be because of it mostly manifests after like mostly a immune infection. Okay, mostly a mucosal infection. So with this, what is going to happen? What will be the immune complex? IgG plus IgA, they are going to complex and get deposited. Okay, they will deposit where? In the glomeruli. What are going to be H&E findings? You won't see anything on H&E and EM. You just do immunofluorescence, and that is going to be what? In immunofluorescence, you're gonna have IgA immune complexes on IFM. Okay, that is it. We have done the main points of all the nephritic and nephrotic syndromes. If you want to take a screenshot, you can. So I'll give you a couple of minutes for that. So this is nephritic, and let's do nephrotic as well. So this is nephrotic, and thank you so much for watching.